Sorry about that. Oh, then I hit the wrong button. Okay, there we go. Okay, so transitions of care is when we move from one facility to another, or it can actually be within one area of the hospital to another. So if somebody moves from ICU to medical floor, or from the psych unit to the medical unit, that's also considered a transition of care. And why do we care about this for older people? Well, in the United States, we're getting older, right? I think it was about 10 years ago, the first baby boomer turned 65, and over 10,000 people a day in the United States turn 65. And it's supposed to be like that for another decade. And that's a majority of those people that are discharging from hospital to nursing home. We also think about when I first started at Lake Region, but then with my work at long-term care facilities as part of our consultant group and assisted livings and those type of things, people stayed in the hospital a lot longer, right? We had swing beds and those type of things. Well, now people move as quickly as possible due to insurance and other factors to long-term care. And then all of a sudden, then maybe after a short stay, they go home. And so there's a lot of potential problems that can happen as we go through these transitions of care. And hospitals want to do well. CMS wants us to do well. There's a lot of long-term care scoring as far as if you readmit within 30 days and there's certain diagnosis like CHF and MI that you're not supposed to readmit for that same diagnosis within 30 days. And so healthcare systems and other places know that we should do good on these things, but there's reasons why they're difficult. And so just to throw a few stats at you, it's been studied that when people move from one level of care to another, there's a lot of potential for adverse medication events. Maybe taking two of the same medication, taking medications they're not supposed to, and we'll kind of go through some of those examples. And there's been other studies that show how many medication discrepancies there are when people go from long-term care. And so I kind of like memes. And so this one as far as the hospital, but sometimes this is kind of why there's issues in transitions of care. There's so many things that have to go right for someone to leave with the right medications and then pick up those medications and then take them correctly. And it seems like whenever there's problems, we build on more processes that we think are going to help, but sometimes we have some of those unintended consequences. And so when we look at the reasons why people readmit to hospitals, many of those things are related to medications that we didn't get proper lab work. The patient or caregiver didn't understand all the meds. I mean, we don't feel well. We're scared as the caregiver or the family member, and there's just so many things going on that even somebody that works in healthcare, we have enough trouble trying to keep everything straight. When you don't have that healthcare training, it makes it even harder. Maybe we can't afford some of those medications, and that's the reason we don't pick them up. And our CHF doesn't get any better. Our COP doesn't get any better, and we end up back in the hospital. We're not sure because we see different doctors throughout our stay in the hospital, which are different than our primary care doctors, which maybe we also have specialty providers for, we have arthritis or diabetes or whatever, and there isn't really time built in for all those people to talk. So sometimes we end up with adding meds that cause more interactions and potential for error and those type of things. And so again, a reason that health systems are trying to get pharmacists more involved in some of that process, but there's really nothing formal in most areas after the hospital. Some big areas do. And so this diagram kind of shows what happens. The hospitals are trying to do everything they can. We're building in processes. We're trying to do communication. But when everything just lines up in a certain way, we end up with some potential drug problems or problems with the medications that cause people to be readmitted. And so things that some health systems are doing and some of us smaller facilities are trying to do more and more of is having pharmacy make sure they're talking to the family and patient, especially when they're on new medications prior to leaving. Thinking about which people maybe are the most high risk. They're on 10, 15 medications. They've been hospitalized multiple times. And maybe that's a time when they sit down with a PharmD and then go to their provider and look through all their medications. Look at what labs they're supposed to get. Are they having any side effects? Are they having any cost issues? And then kind of write up some more formal recommendations. MedRec, again, a lot of times, a lot of us maybe with family members, other people would get frustrated with having to say that medication list every time, but there's just so many potential reasons why our computers, our health records at the different facilities aren't up to date. And there's just a lot of issues there. And so that's why we constantly have to be trying to make sure that we're on the right medications at the right time for the right person. And so, I think for the future, I think we're going to have, groups and have provider, nursing, social work, et cetera, along with a pharmacist that kind of really look at these high risk people and work with them to make sure that they're not having any problems, that they're staying out of the hospital, they're staying in their homes or wherever they want to be and not having to go to a higher level. But we're not kind of at that level yet. The study cited there in AGHP, actually, they have a group that included paramedics, psychiatrists, pharmacists, nurses, social work, and kind of looked at some of the people that were frequent hospital visits, and they showed benefit in preventing those people from having to go to the hospital. We know we have to be better with communication with our electronic records, and I'll talk a little more about that. Needs to be some changes in how things are paid, that maybe we spend a little bit more money outpatient wise and maybe try to so that we spend a little less in the hospital. And so I like these next two slides that kind of talk about some examples that your seniors might see and the things that we're trying to prevent when people go from hospital to home or long-term care to assisted living or wherever it might be, is prevent those medication errors, because we all know the stories of people that go from one area to a hospital and then they come back with medications that they haven't been on for 2 years. And that's sometimes related to the provider in that facility. It's like, oh, they were on these medications 2 years ago, just continue those. And they don't have the current records, and maybe there isn't someone with the patient, or the records aren't sent along to show that those medications aren't even active anymore. Newer worsening condition, best example here is a lot of times maybe like ibuprofen or naproxen, like the NSAIDs, can sometimes cause higher blood pressure for people or make their edema worse. So maybe those meds added to why they got hospitalized, and they were taking them over their counter. They go to the hospital, no one figures out that that was the cause, and so they go home and start taking that medication again. Formulary changes. Many times when people go to the hospital, we need to switch them to medications that are maybe less expensive for the hospital, or it's impossible to keep every medication from every single class that there is, and so they get switched. And so the potential is there for people to take two of the same things, or the hospital has one thing, but then their insurance covers something else, and now people are on two different insulins. And I don't know about you guys, but pharmacists get confused on all the different insulins. There's so many different products on the market, so many now kind of generic or kind of bioequivalent type insulins that it's very confusing. Over the counters and herbals can be missed when people go from transitions of care, and many of those medications can interact, with some of those meds. Again, I'm not against over the counters or herbals. It's like, but we should just know why we're taking them. Are they actually helping for that reason? Are they interacting with anything else? And are you not taking your hypertension meds or not taking your cholesterol meds because your over the counters are too expensive? So those are just all things to kind of think through. Also, another one that you commonly see is many times from the hospital, we need blood thinners for a short time or maybe weeks or months. But sometimes those orders don't get communicated right. And so people stay on them way too long or stop them before they should. And that can have some really bad consequences. Also, patches can get forgot about in the transitions. Potassium is one that sometimes gets forgotten and left on, when people stop their water pill or their diuretic. There might be drugs that there's so many people on specialty medications that, we only take it once a week, once a month, every 3 months. And if you don't have good caregiver support, which you guys know all those people out there that don't have that, to kind of keep track of that, it can make it easy to miss some of those meds. And with some medications, it doesn't take a lot extra or not many doses of not enough of certain meds, and it can have some major side effects.
Mark,
yeah,
someone just made a comment that so many times seniors, they hear or see something on social media or TV about a side effect or a drug that's supposed to help, and they think it's the gospel. So they'll either quit taking what they have because they've heard it has a bad side effect, or they'll ask their doctor for a new pill because they've heard that it's supposed to be really good.
Exactly. That goes right into polypharmacy that we'll talk about later. That in this country, we're kind of programmed to take medications. We see all the advertisements. We think, yeah, geez, maybe that's what I need. And it just adds to keep adding more and more and more. So other questions, Judy, do you have on there, or anybody want to unmute?
There's nothing else in the chat. Does anyone want to just unmute and ask a question, or are we doing okay?
Okay, perfect.
Go ahead, Mark. I'll keep watching the chat for you.
Yep. And so it's interesting. There's a coalition or a group for everything, I think, but there's actually a national transitions of care coalition, and they kind of talk about the best things that we can do for transitions, and there's many things that for medication that we can do is making sure that we're on the right meds, whether it's post hospital, long-term care, at any point, just kind of doing that checkup to are we on things that don't cause interactions, etc. So, and then you can kind of read through some of the other things that can help. So MedRec, and so more and more pharmacists are getting involved in hospitals, and especially in emergency rooms for the people that admit from the emergency room. So nurses do an excellent job with MedRec as well. But again, as we keep adding medications to the market, I think there's something like 10,000 FDA approved meds or something like that. Sometimes it's nice to have the medication experts at that point to make sure that we get the right medications from the start. And there's so many different forms of different medications and all those type of things. Discharge counseling. So again, really making sure that people know the medications they're taking. And a lot of facilities have also done meds to bed, so they actually make sure that the medications that they're ordering are actually covered by their insurance, and that people have them, so that it's like, oh, I didn't feel well enough to actually get the new meds filled, so I'll fill them later. It's like, well, that's not a good idea for a lot of different classes of medications. again, there's just more studies that kind of show that if we get pharmacists involved, that can help. I don't think we need to like spend a ton of time on some of these things, but again, looking at more of that interdisciplinary team, having people that work directly with some of these caregivers and kind of identify some people at risk. And if they were able to get them into some type of program like this, it would definitely help. And there's a lot of studies in heart failure that show that the multidisciplinary approach can definitely help. And there's also studies that show that community pharmacy can help, but the ones that have shown the best benefit are some ones that kind of are unique in that they have the EHR available as kind of a read only, so that, say, in Fergus Falls, if one of the pharmacies had access to the clinic records to be able to see the lab work, what the doctor has for diagnosis and all that sort of thing, those type of things would help out to kind of be that double check. And that's why, currently there's a little bit of a trend to have pharmacists working right in the clinics, that are right with those physicians. So I think about like in Fargo at Essentia, at one or two of the clinics, they have a PharmD that meets with people right before their visit, and then addresses with that provider right away what potential problems they see, so that it kind of speeds up the provider's visit because they know what things to look at as far as their medications, and then they can spend more time on maybe the physical exam and some other issues. So, okay, any other questions in the chat here before I move into polypharmacy?
Before you move into polypharmacy, just I've always stressed to seniors whenever I've done presentations or whatever, how important it is if they can use the same pharmacy. Does that still ring true?
Yeah, it really does. That gives us the best chance of, that pharmacy being able to check all the interactions, be able to run through their program. The sad reality is, now there's so many prescription things that can be obtained over the counter. So then that's not going to be in that profile necessarily. So many drugs that have to come from a specialty pharmacy, that it's required, that the only way you can get it is through that specialty pharmacy. So it's harder and harder. I mean, that is still the ideal and best practice if you can, but there is a lot of reasons why people can't do that. Great point, Judy. Okay, should we move into polypharmacy?
Yep. Oh, hold on just 1 second. Here's one question that came in. Are there services out there that can consult with people over their meds? So maybe explain that you can do that, Mark.
yeah, perfect. And that'll be kind of our last few slides, is kind of our role with medication management to do some of that stuff. So perfect question.
So hang tight, Larry. We'll get to your, we'll answer your question in a little bit.
Yep. Okay, so we've all, many of us that have been to anybody's houses that have a lot of chronic conditions can definitely empathize with that bowl on the left and all the medications. And so they actually have a definition for polypharmacy, and maybe a better way of saying it is we have multiple definitions, and that's why it's kind of hard to study it in the literature, because everybody kind of puts a different spin on what exactly it is, and really no consensus. Most common, they talk about 5 or more medications. Some definitions range from 2 to 11. I've seen also where there was one author that even said 1 medication. If you have 1 medication and it's not appropriate for the indication or causing side effects or whatever, that would even be considered a polypharmacy. And so I think a better way to think about our medications is there reasons? Do they have benefit? Are they not causing side effects and those type of things? That's what we want to try and get to. And we want to stay away from the diagram on the right. We want to stay away from, they never should have been on that medication. This medication, we started it and it didn't do anything for the blood pressure, didn't help. Well, should we add on another thing? no, maybe we should stop it if it didn't help at all and go from there. Adding over-the-counter supplement use because our family member said, or the person who cuts our hair said it was a good idea. And we have no idea why we need it, but we're taking it. And then there was a lot of medications that were the right medication for people, but we don't need it, 3 years later. My classic example there is iron. A lot of times post-surgery, we lost some blood and we're anemic and we need some iron for a while, but that doesn't necessarily mean we need it forever. For some people, they need it, but others don't. And so, are we checking the right lab work and doing that type of thing? So, so as we get older, we're going to have more potential for having diagnosis, right? If we live long enough, we might end up having some cognitive impairment or some dementia. If we live long enough, a risk of hypertension, or for guys, BPH, very good chance of those things. And so there is chance for more medications as we get older. The things we can do, and we'll maybe skip through that, but again, if we have a pharmacist in the care team, if we do kind of the med reviews and some of what our group does, it's something that can help. Other things that we can do for the providers is sometimes kind of giving them presentations like this one and reminding them, of looking at maybe stopping meds before we start them, ruling out that maybe the medications are causing some of the side effects and go there, or maybe looking at maybe certain physicians have way higher amounts of certain drugs than other physicians. So we look and it's like, why does this physician use so much more proton pump inhibitors or use so much more antipsychotics or whatever it might be? And maybe kind of look at, is there reasons, are your patients different? Or is it something, we maybe need to review a little bit more? And so then the consequences of having like that dish on the left that we saw before and that huge bowl of medications is after a while, we can't remember how to take it anyways. We're sick of taking pills. So we just skip some of our times when we're needing to take medications, and we don't understand which ones are really, really important and maybe what things, maybe aren't necessary. We want to stay out of the cycle of a medication causing a side effect, and then we recognize that side effect and we say, oh, we have a medication for that, so we add another medication. And so we just keep going round and round and round. And then the more medications we have, the more chance for med errors, for drug interactions. And so, like we said, as we get older, the more chronic conditions we have, the more chance that we're going to have more medications or polypharmacy. And so actually, this Lown Institute in 2019, they're kind of this bipartisan think tank that try to look at major issues and try and think of, why they're happening and things that can be done. So back in 2019, they kind of looked at this medication overload problem. And specifically in the United States, we really are, kind of programmed. And so we think that, in our providers, a lot of times prescribing is kind. If people aren't feeling well, everyone feels better if we write a prescription for something. It's like, now we have something to take care of that problem, even if that's maybe not totally the right thing, or maybe it ends up causing more side effects. Maybe the classic example is if we totally have a viral infection and people demand antibiotics. You can get a bacterial infection on top of your viral infection, and then you might need antibiotics. But if it's all virus, it's not going to help, have an antibiotic. And so by giving antibiotics when we don't need them can add to more resistance and side effects and those type of things. And so we think we're being kind. And all of us that have been to the clinic, we know the surveys that come out, many times people will rate providers lower for not writing prescriptions. And so that kind of puts a spin on for physicians and other providers that they need to write for something or people are going to mark them down, and maybe that's tied to their bonuses, etc. If they have bad surveys.
They need,
Um,
they need
go
to
ahead.
write, they need to write more extra prescriptions for evidence-based programs for exercise and healthier eating, maybe, huh?
Exactly, because yeah, we want the quick fix. Yeah, like,
Right.
geez, I don't have time for exercise. I don't have time to, or I can't get those eggs, right?
Yeah, yeah.
This-
Someone did make a comment in the chat about how their grandmother had had knee replacement. And 5 years after the knee replacement, she was still taking the pain meds because her doctor said so. Her doctor had prescribed them, so he never told her to stop. And so she figured she still needed them. She said her
Yep.
question is, why would the doctor still authorize that?
Yeah, it's those are the things that happen, and the questions that happen. It in our systems, it seems like it's almost easier just to kind of refill things and not change the order, just keep it the same, rather than trial something else, which we'd have to write a new prescription and write new directions maybe for tapering off. It's a little bit more time consuming at the time to taper off some of those things. So that's what happens. And sometimes we're not the best of, none of us like going to the clinic if we don't have to. If you're on quite a few meds and have diagnosis, we should be going in and checking up, yeah, what is the plan with the diabetes, with the pain meds, etc. And so it's a little of both. It's a little of us as healthcare workers, and it's a little of us programmed that we don't want to go to the doctor. And it's like, we'll just keep doing the status quo, and yeah, for the pain, that's a perfect example where acute pain is treated so well by certain meds, but once it's past 6 months, then we're kind of into that chronic pain. And a lot of our meds that we typically use for pain don't work as well. And we really should look at something else if we're still having pain. So that's a great example. We talked about the direct-to-consumer advertising. It's everywhere, right? Can't sit through a baseball game without hearing how many advertisements for whatever erectile dysfunction drug, right? Or can't sit through whatever and hear about the newest allergy things or and those type of things. So people are kind of primed for prescriptions. Also, think about like the guidelines and like Judy said, like evidence-based, people want to be evidence-based with their regimens. And sometimes the thinking though, is that it's like, we're trying to be evidence-based for diabetes or CHF or MI, but did those guidelines take into account our 92-year-old lady that lives at home still, and what she wants as far as quality of life, or what her goals and all those type of things. And always think about that age and those type of things. Maybe a better example is like, sometimes in long-term care, you'll see people that the docs decide, yeah, we're not doing a statin, because we think the risk could be more than benefit, et cetera, et cetera. Well, all of a sudden, this 102-year-old will have a heart attack, go to the hospital, and now they're on 7 new medications. And it's like, if the plan was for a heart attack that you were going to then come back with a statin, aspirin, Plavix, beta blocker, ACE inhibitor, maybe we should have kept the statin. So I think we need to kind of think about advanced directives and what people want to do and those type of things. So, and that's not fun stuff to do. You guys all know that. Okay, and then industry influence. I think there's been a lot of good things to take industry influence out. But one major piece of this is we don't have manufacturers that are funding studies to stop medications, right? No one's gonna pay for that as far as in the manufacturer level. These are publicly traded companies that make money. So, okay, another one of my bad memes. Medication for side effects. So contributing factors, and we've talked about some of these already. And it takes more time to kind of look through, maybe just with that pain med. Yeah, it takes some time to think about, yeah, what is the plan here? What are we going to do to change? What happens if pain does come back, and those type of things. So that continues to be a problem. I just wanted to, the prescribing cascade. So my classic example there is, I like to pick on NSAID. So ibuprofen many times can cause worsening edema. So then, okay, instead of maybe stopping the NSAID and using Tylenol or using something else, then we have edema. So it's like, well, we'll add a diuretic. So we add Lasix to take care of the fluid that's building up on our legs. Well, that reduces potassium. So then we add potassium. Well, the potassium can kind of be hard on the stomach. And now, we got some upset stomach. Maybe we add a proton pump inhibitor. Well, proton pump inhibitors long-term can maybe have some effects on bone. So it's like, well, maybe we should add some more vitamin D or calcium. And so the calcium, constipation. So it's like we keep adding and adding. And at some point, sometimes we need to look at, was that first drug or one of those drugs along the line the cause of some of those side effects, and what we should actually work on. And so just more stats. And I sent this PDF to Stephanie so she can send to anybody that wants a copy. But again, just kind of goes through all the things that medications can make worse. And sometimes when I'm doing this talk, we do have to remember that the reason why we live so long in, this area of the world is because of the medications and medical advances that we have, and due to the vaccines that we have. But we do have to be a little strategic about those medications. Doesn't mean that, they're always good. We need to kind of critically think about all the things that we're adding and ask questions on when we can go down. And because if we look at drug interactions, when we get to 5 to 9 medications, there's a 50% chance that there's some type of interaction. And that doesn't mean you maybe have to stop the medication, but it might mean you need to decrease or increase some of the other medications. And then if you get to over 20 meds, which is not uncommon at all to see for some of our geriatric people, it's a 100% chance that there's medication interaction. And so from an old study, they looked at all the long-term care facilities in North Carolina, and for every dollar that was spent on medications at that time, $1.33 is spent on treating the problems. And so in the outpatient world, the best guesses is for every dollar we spend on medications, we spend $1 taking care of the problems of those medications. So if enough people are on ibuprofen, it's going to cause a GI bleed, or it's going to cause CHF. And so again, it's always risk benefit, that sometimes we have to use some of those medications, but then for other people, we have no idea why they're still on them. Are they still needed? And so the main thing that we do through area agency is kind of do like the medication therapy management. And so people can contact our group to either come to senior center, assisted living, we've been at churches, etc., and kind of set up our appointments for the seniors. And we go through, look at all the medications, talk through what's going on, and then we type up a letter that then goes back to them to bring to their next provider appointment to kind of discuss what potential medication changes might happen. And sometimes we do have to say, maybe we should take a little bit more vitamin D because we're not getting much from the diet and we're on certain meds. Or some of the recommendations are, you haven't had labs for over a year and you're on this med, that we really need to make sure that you check, your kidney function, your hemoglobin, whatever it might be, for those type of things. Let's see, what else? Some people that really should think about making sure they review their medications with somebody is people on blood thinners, that are on medications for diabetes, that are on long-term opioids. those are people that are at much higher risk of requiring an emergency room visit for a lot of reasons. The hypoglycemia, can lead to falls and confusion, etc. Blood thinners, if we fall, obviously can have bad outcomes. And so these are kind of the questions that when we sit down with a senior and or their spouse or caregiver, the things that we'll talk about, are there reasons for each of the medications? And if there's not, to put in kind of a non-threatening way to the provider, that we're not clear on, what the reason why this medication's on there, or this person isn't taking it the way it says on the bottle, what is the right way, or does that need to get looked at? Is there some new drug interactions? And all of these kind of questions go back to, we see lots of different providers. If we get sick, we go to the walk-in clinic or the ER. Hospitalized, we'll see hospitalists. And people have specialists, and it's impossible for those people, the way our current system is, to make sure to check if all these things are correct. And it's really hard for those providers to say, oh, geez, you've been on it for 5 years. I'm not going to mess with stopping it. So a lot of times, that's how a lot of those things just keep getting continued, even though they might be part of the problem. And we want to stay out of this prescribing cascade where we keep adding more meds that add to more problems. So we don't want Oprah saying, you get drugs, all those type of things. So here's just some examples of medications that cause specific side effects. This slide is a really nice one as kind of a reminder to think about if somebody has, either severe or new issues with any of the following, there might be some definite medical reasons why that there's issues, but we should really also think what medications might be causing some of these things, and specifically think about what started recently, what stopped recently. And you can't think of it as just that drug. It could be a medication interaction with something else they're taking, lots of different things. But whenever, and I get this question a lot, like providers or nurses will ask and go, can we get something for this person not eating? And again, we can't be the ones that help add to the more meds. It's like whenever you see a problem, pharmacists that review meds should be thinking what things might have caused this or might be contributing to the issue before we add another thing. It's easy to find potential meds that might help with a certain symptom, but we can't be programmed into doing it that way. So then here's all the things you think about: communicating more, shared decision making, talking with the family and the patient or the senior to say, what do we want to do? This drug has a 20% chance of helping out, but it also has some potential side effects. What are your thoughts on giving it a try or not? So yeah, and a big one there, routine prescription checkups. Whoops. And so we talked about MTM, the med management history. We kind of talked about that history, and I think why it's been successful is it kind of tries to catch some of those people that are really having some kind of trouble with their medication and, not sure where to go. Maybe you don't have like an MTM benefit with other pharmacists, or if there's a group that in your community that, a bunch of them that would like to have a pharmacist come in. And why it's been successful is our consultant group, our group from Lake Region, we're not facilitated with any pharmacy that dispenses meds. We don't care where people get the medications. It's just totally looking at, are they the right medications for you? Or what things do we need to monitor to make sure the right meds? So some of the best recommendations we have for people is that it's like, yeah, you're having these issues, but you never check your blood sugar. We need you to check your blood sugar for one or two times a day for a week before that next appointment. Bring those values or bring those blood pressure values, do a blood pressure sitting down and one standing up, bring that along to your provider, and we'll know what to do from there, or they'll know what to do from there. And so obviously challenges is now we kind of, we haven't been traveling to a lot of the nursing homes because we're doing a lot of the visits virtually. Are doing over in the EHR where we're doing our reviews. So we're not kind of in some of the communities quite as much, but we've started to get back to a lot of the long-term care facilities. So we drive through a lot of the counties and towns that you guys all spoke about. And so, if we can get 4 or 5 people at least, maybe we can do it in a community, but maybe if it's more of just a 1 or 2 people that you have and it's a long ways away, we do have potential to do like virtual appointments that are secure through doxy.me, or for some people, maybe it works better to talk with their caregiver or their spouse over the phone. And, it just depends on the situation, because you guys know how complex some of the people that you work with are. So Judy, I think I'm getting close to my time here, and we got to leave some time for questions.
Okay, sorry about that. My mouse was acting up. I couldn't unmute myself. Yes, so as Mark mentioned, he's got his contact information up here. You can also contact one of us and we can get to Mark as well. Mark's presentation, if people are wanting to do some stuff in person, it's great for senior centers, nutrition sites, those types of things. But sometimes people aren't comfortable going there yet. So like he mentioned, you can do through DoxyMe and do some virtual stuff. It's some good information. It really truly is. And so much of what you say, it makes sense when you sit back and think about it. But so many times our seniors, the doctor said, and that's the gospel, and they take it, and not saying that doctors are doing this facetiously, but they might not know that you take this other thing over the counter, or that type of thing. And Mark's group can help them walk through that to look at some of that stuff. Are there any other questions? I will send out the PDF of Mark's presentation when our day is over, so that you all can have it to see. But please feel free to unmute yourself and ask any questions that you have. Excuse me, or you can still drop them in the chat as well.
Hello, Mark.
Yeah.
Thank you for the presentation. It was very interesting and helpful. We have a program that we're reaching out to rural seniors in rural areas here that are living alone as kind of a reassurance program, telephone reassurance program. I'm wondering, do you have any tools are there any tools that that can be used to like chronicle, if we're going out and doing an intake with them, kind of chronicle their medications and maybe even their med history a little? Is there something that's out there available? And then these would be more likely situations, like you're saying, that single person, that single incident. So a lot of interest in the service that you might be able to offer, or any other services that of that might be able to take that information and kind of review it for any potential issues.
Yeah, Larry, good question. I'm almost thinking maybe I'll have Judy send like the forms that we have for this program, because like the one intake form might be something you could kind of use to kind of remember all the things to get from people, their allergies, meds, put prescription meds, over the counters, herbals. So that might be like a tool that can maybe be used in that format. And yeah, for sure, just email or whatever, or call with whatever you're kind of thinking, if there's somebody that we should contact and that type of thing. So, and yeah, and we do it kind of different, just depending on the situation. Sometimes like if it's assisted living person, maybe it's like that, that copy of that letter we talked through senior or family members, that it's like it's going to go to them, but then also a copy to the assisted living or whichever other home care that's working, so they have a copy for their chart as well. So
right, that's great. Thank you.
Chat in there, Judy?
Pardon?
Oh, sorry, was there a new chat in there?
Oh, yes, there is. Can you provide any insight with med management with someone with dementia? Julie, do you want to unmute and
Yeah.
maybe clarify your question, please?
Yeah, sorry, that was a little broad. So I am working with a family who the wife has dementia, and she absolutely refuses to have anybody take a look at her medication. She was in the ER several times due to, she was taking 2 different types of blood thinners because she will not let anybody touch her medications. And she forgot that the doctor discontinued a blood thinner. And so she doubled up instead of taking that medication out. The family is at its point, they don't know what to do. They've went to the doctor. The doctor really isn't concerned. I'm just wondering from a pharmacist standpoint, if you have any recommendations.
Yeah, that's a tough case, and yeah, almost a vulnerable person, right, type of thing. So yeah, I mean, well, right away I was kind of thinking through that. It's like we've had the examples where I've had people that have been referred through senior linkage line that, you know, the family member was irate with the medications that this person was on, but they were actually in a facility that we don't go to, and just totally didn't understand why they were on certain meds. And in that case, it was more of just kind of walking them through the questions to ask. And I think that went pretty well, because it was like they went through all the medications, kind of said what was happening as far as pain and confusion and that sort of thing. And I was able to kind of walk through that. It's like, you know, these certain things are totally what anybody would use, but there was a few things that were a little odd, but it's like, here's the questions to ask and then go from there. And that seemed to go well. And so like in a case like that, yeah, you don't know if like having an outside person, you know, review the meds and maybe having it down in writing, but it sounded like that they're maybe past that they weren't going to listen to probably anybody with their meds. And I don't know.
Mark, is that something where the family could speak with the pharmacy where they're getting the prescriptions filled? Would a pharmacist look and say, hey, this person's on 2 blood, and the pharmacist would reach out to the physician?
Yeah, that could be a possible option too. You know, if depending on if like that person's, you know, authorized caregiver to talk to the pharmacy on that person's behalf. So that is why it's difficult. It's good we have legal services coming in this afternoon, I think.
Yes, definitely. So I know, Julie, so maybe give you a couple ideas. Mark, are there, do you have something written down for like questions, common questions to ask for that type of situation that maybe we could share?
Common question. Yeah, I mean, I just think maybe going back to that, you know, the indications, you know, going through, you know, all the questions that we're supposed to see if they're appropriate, you know, and so in that case, it's like, yeah, you can use, it probably was Plavix and aspirin, I'm guessing, or else it was like Eliquis and aspirin. And it's like, there's times when you use those medications together, but there is some drug interactions and possible duplication. And so that's why your doctor is saying we want it discontinued. You know, so yeah, but.
And I'm thinking, Julie, too, maybe if she doesn't want anyone in the family to do it, maybe if they've got the right that they can talk to the physician, maybe the physician would write a letter so that she could see that the doctor said, no, stop taking this one. Then maybe, you know what I mean? It's hard because depending on what stage they're at, I mean, you maybe could pull one med and they wouldn't know, you know, but if she's still cognitive enough that she knows that, then maybe just a letter from the physician would be enough to say, oh, my doctor says I need to stop taking the aspirin with this. So, okay, I'll do it.
Yeah, that's a good idea, Judy. Or just printing out the progress note. You know, so many of the EHRs are available and online and stuff, but maybe the doctor the office could just print out that progress note and it says in black and white, you know, Plavix discontinued or whichever drug it is.
Right.
Sean had a comment about whether it would be possible to get the prescriptions in a pre-packed system where they were, what are they called, Mark? I can't think of the name for it. The pill
Yeah,
packs?
just pill packs or bubble packed and stuff. That's a great idea, Sean.
Good idea. It's a tough
I
one.
have recommended that to the family. It's a tricky situation. I have recommended that to the family. I also recommended intercounty nursing coming in and setting up her medication. That lasted one trip. And this woman told the nurse, "Don't you ever set foot in my house again."
I used to do my mom's, then she'd dump them all out and tell me I did them wrong.
Yes. So it's really, really tricky. So I think what a good suggestion is the note from the doctor. And
If-
hide it, enlarge it, and put that with her medications and hopefully that will work. So
Yeah,
thank
because if she trusts her physician, then maybe that just will be enough. Yeah. Good luck.
Great. Thank you.
Yes.
Maybe even if they brought all the meds in, with the patient to the doctor, and the doctor basically says, you can't take this bottle anymore.
Mhm.
If I was the provider, I'd be like, I can't be your provider anymore if you keep taking this medication.
Yep.
Yeah, because the two medications is Eliquis and warfarin.
Okay, yeah, that's those, cannot be used together. So,
Yeah.
there's a reason. You can overlap them. But yeah, that's just asking for huge trouble.
All right. Well, thank you so much, Mark. Again, I said I will send out this presentation so that you guys will have, you'll be able to print out a copy of these of these questions and have Mark's information at the end. Again, please always reach out to Dancing Sky as well if you can't get a hold of Mark, because we can certainly help make a connection and go from there. I think what we will do right now is